Do you know what's new for nurses? What about dementia and caregiving? Are you looking to grow as a leader? And what are the current healthcare leaders doing for you? Welcome to the Angie Graham Podcast. Ladies, my healthcare ladies, all of my professional women out there, and any women that are watching the show today, we are continuing our conversation about menopause. So before you make any major life decisions, you have to ask yourself, is this perimenopause or menopause? Do I feel different? What is different about me? With us today, Dr. Clifford Gluck, physician and owner of Dr. Gluck's Wellness Center in Boston. Dr. Gluck is a board-certified urologist with more than 30 years of private practice specializing in sexual health, hormone therapy, and urology. So welcome to the show, Dr. Gluck. I'm so glad you're here.
Thank you so much, Nikki.
Yes. So just to get it into it for women, that how do you know if you have perimenopause or menopause? What do some of those symptoms look like? And how can we identify those?
Well, perimenopause, as you know, can begin a decade or more before menopause. And it usually is first recognized by some changes in the timing of a woman's period. But the earliest signs are often not dramatic hot flashes. More often, they're changes in the pattern and resilience of a person, changes in their life. And a woman who used to sleep well starts to wake at 2 or 3 in the morning. A woman who used to juggle stress easily now feels overstimulated, more irritable, less tolerant, or emotionally thin-skinned. The cycles may get shorter before they become irregular. And brain fog can show up as trouble retrieving words, decreased focus, and a sense that mental sharpness is less reliable. The Menopause Society notes that cognitive symptoms such as forgetfulness, distractibility, and difficulty concentrating are common during the transition, and vasomotor symptoms themselves often worsen sleep and mood.
So we're not crazy. We may think about we're crazy, but we're not really crazy.
There are
Right?
reasons to act crazy, and those reasons are something we need to address.
I can remember, I'll be honest, I've been so busy with my career for so many years. And I do remember this shift happening. And now I recognize this was perimenopause. I just didn't know it. But I remember I became a lot more irritable about things. And I recognized that in myself. And there were times that I had that experience of like, I would say to myself, I can't even stand myself right now. Why am I so just ornery? And now looking back, I can see that this was perimenopause. And I was so busy living, and no one was talking about it. I was so busy in my career, and I didn't even really catch on to these early signs.
And it sneaks up on you. It's shocking, I know. But
Yes.
you're not alone. You're in great company because this happens to most women.
Yes. And I am excited to talk about it because it advanced for me into menopause. And I questioned what my future was going to be. Could I continue to perform at this level? And then when I sought out medical treatment, there was a huge gap there. They put me on antidepressants, and I said, I'm not sleeping. Well, we'll put you on an antidepressant, and we'll do this, and we'll do that. And then when I asked about hormone therapy, I was told that it may be a possibility, but you can only take it up until you're 60. So one of my first questions I want to ask is, when is it appropriate to think about using hormone therapy for the ladies that are watching? And is there any age limits on hormone therapy?
Well, the answer to the first question is it depends. And the answer to the second question is not really. So
Okay.
when we're talking about when to initiate hormone therapy, it really depends on when symptoms are appearing. And that can be at almost any age. Some women undergo very, very early premenopause or perimenopause, and some women are are hanging on into their 60s, still having a regular period. So it depends on when your body is transitioning. Now, if somebody's having symptoms, it's important to address the symptoms. And most of those symptoms are being caused by a fluctuation in hormones, sometimes too much, sometimes too little. And if we address those things, then we don't have to give antidepressants or other kinds of chemicals to address symptoms rather than to actually fix the organic problem that's there.
See, I love that solution because I felt like initially I was just treating symptoms. And the sleep deprivation is what I really hit me hard because I needed to be able to function and I needed to come to work and be on top of things, and getting up at 2 a.m. or 3 a.m. and by noon I was just tapped out. So that was something that I eventually found some help with. But sleep deprivation, that can also happen in perimenopause as well as menopause?
It can, and it is one of the earliest things to happen. And there's a very simple way to remedy that. Sleep deprivation happens because of a loss of progesterone. And as that happens, the brain starts to lose that influence on the GABA receptors. There's gamma aminobutyric acid receptors in our brain that are heavily involved in brain functioning and dopamine signaling and serotonin signaling. Those GABA receptors have to be functioning well for a person to get to sleep. And when they're missing progesterone, then they start to malfunction and you start to feel exhausted but also wired at the same time. And that's because your body starts secreting more cortisol. It's the stress hormone, and it elevates your norepinephrine, and then you can't get to sleep, but you're so tired and you're feeling awful all at the same time.
I have lived this life. It feels so good to hear that there's a reason for it because you feel a little crazy. You're like, I'm so tired, but why can't I sleep? There's still a lot of confusion about hormone therapy. And a lot of women are still very scared of it. So when the FDA removed that black box label back in November, how, as women, do we overcome this fear of, I'm afraid to use this? What would you say as a physician?
Well, I would say as a physician, we're finally getting around to being sensible and looking at the science behind things instead of misinterpreting old data that didn't make any sense. I mean, it's helpful to have a little bit of perspective on exactly what did happen. In the late 19th century, women were starting to undergo this new operation, a hysterectomy and removal of the ovaries, because there had been advances in surgery and people didn't automatically die or become septic from having an operation. And in taking out all the equipment, there was a loss of hormones. Women felt terrible. It was early menopause for them. And so some thoughtful physicians and scientists thought that they might take ovaries and try to extract whatever's in the ovary and give it back to people. That was the first hormone therapy, predating anything else. And it actually helped. And the same thing had been done with thyroid, taking desiccated thyroid from animals such as porcine and bovine sources and giving it back to people. So from that, in the 1940s, scientists were able to extract estrogens from pregnant horse urine. They called it conjugated equine estrogens, and you may know it by the name Premarin. The FDA approved it, and it became something of a extremely popular drug to give to women who were having menopausal symptoms or had gone through menopause. And at about the same time, diethylstilbestrol, DES, was synthesized. And those drugs sort of revolutionized that estrogen loss that had been happening. In fact, in the 1960s, a fellow named Robert Wilson wrote this book, Feminine Forever. And women who were actually starting to really think about their bodies and about liberation and about their role in society and life, decided, yeah, I want to be feminine forever. And that meant taking
Yeah.
hormones. And so hormones really became quite de rigueur. It became the thing to do. And about the 1970s, so many women have been taking unopposed estrogens that many of them, well, a significant number, let's say, had developed endometrial cancer because they were taking unopposed estrogen. So progestins began to be added. And that's where conjugated equine estrogens, or Premarin, and Provera, that manufactured progestin, came together to help prevent endometrial cancers. And then in the 1990s, there was an interest in bioidentical hormones. Beta estradiol was manufactured, as well as natural micronized progesterone. You could make these hormones from vegetable sources like beets, for instance.
Interesting.
But these compounded hormones were not FDA approved, and also they they weren't able to be patented because they were natural. They were substances that our bodies already make. So the drug companies really had no interest in them. They wanted to produce things that they could charge money for, lots of money, billions of dollars
Of
from
course.
selling these things around the world. So it became an issue because of the number of women who are developing other kinds of illnesses. Were these illnesses from hormones or were they not from hormones? So the first study that's notable was the Heart and Estrogen Progestin Replacement Study, the HERS study, HERS. And in that study, they put together the conjugated equine estrogen, or Premarin, and the medroxyprogesterone, or progestin, that's Provera. And they looked at women who were already pretty sick with cardiac disease. And they were looking for a reduction in cardiac events because the hypothesis was if you take hormones, you're going to be healthier. And guess what? They weren't. In
Okay.
fact, in the first year, women actually got sicker in the hormone group than they did in the non-hormone group. And this led to this big study on chronic disease called the Women's Health Initiative, which
Okay.
is very famous. And in the Women's Health Initiative, they had different arms, but two of the most important hormone arms were the CEE, the Premarin plus Provera arm, and also the CEE Premarin alone arm. That was given to women after hysterectomy because we knew we didn't have to worry about endometrial cancer. The uterus was gone. So interesting. In 2002, they stopped the arm which had Premarin and Provera. Why? Because these women had an increased incidence of cancer, stroke, and heart attack. And they said, hormones are bad. We can't give them hormones anymore. They went on a couple more years. In 2004, they reported the data from the Premarin study alone. And they found something really interesting. They found a lower incidence of breast cancer in the women who had been taking estrogen. So
Profound. Yeah.
profound, exactly. So eventually, first of all, the FDA put these black box warnings on. That answers your question. Why were
Mm-hmm.
they put there? They were put there because of the WHI study, and
Okay.
they remain there until just this year. This has been 24 years of black box warnings for really no good reason. Because we know that hormones don't cause cancer, they don't cause heart attacks, and they don't cause strokes. And that's been proven in subsequent studies. For example, the ELITE study, they looked at oral estradiol versus placebo, and they looked at the carotid intima medial thickness. In other words, how much plaque is developing in your carotid artery. It's something you can measure with ultrasound. And
Interesting.
in the ELITE study, they had two groups of women. They had women right after menopause, and then they had women greater than 10 years after menopause. Now, in the women earlier than 10 years, there was a reduction in strokes and heart attacks. There was a reduction in the formation of medial thickness. In other words, it helped to prevent atherosclerosis. This is the only drug we know of that can help prevent atherosclerosis. Not even statins, which are kind of awful, and that's a whole different podcast of sorts.
Yeah, it is.
are, can do that kind of miracle. But unfortunately, in the women who were already 10 years after menopause, they had developed atherosclerosis, and that plaque was already calcified and really couldn't be reduced by the addition of the estradiol. But at least it didn't rupture or do anything bad. And if we look at what's happening in those women back in the WHI study, why did they have strokes and heart attacks? They were older women. The women in the WHI study, average age was 63 years. These were the women who were more than 10 years after menopause. Different from those elite women who were right after menopause, and we gave them estradiol. So in the WHI study, what happened with that plaque that had already developed? Why did it cause a stroke or a heart attack when you gave hormones? The answer is when you have a manufactured hormone, it has something called matrix metalloproteinase. It's an enzyme, and it ruptures plaque. And so in those women, it ruptured the plaque, it caused a stroke or a heart attack. But if the women survived a year, if that didn't happen to them, that matrix metalloproteinase didn't get them that bad result, they actually did better after they lasted a year. They actually survived longer.
Wow. So is there, very interesting. I did not know horse urine was in this whole story.
Pregnant horse urine.
I definitely learned a lot of things. And then that book in the 60s, that's great information. So is there a way or a better way to get estrogen? Is because that's when we talk about is the vaginal estrogen better than the patch or the oral estrogen? Is there one method that's better than the other? And then also the same with progesterone, because I watched a TikTok too right before I knew you were coming on. I was going to ask this question where there was a doctor saying that you can take your progesterone, even the pill, you can either take it orally or you can insert it vaginally. So a couple of questions to throw at you, but best method for hormone replacement. We're Talking About It is brought to you by Our House Senior Living. Visit us at ourhouseseniorliving.com.
And again, it depends.
Okay.
So, let's talk about estradiol, your bioidentical hormone. Women make estradiol in large quantities, spiking in order to create an egg, which then ovulates, and then you're left with a corpus luteum that makes progesterone.
Mm-hmm.
So estradiol, after you lose it, after menopause is done, in other words, you want to see an FSH, a follicle stimulating hormone that goes above 50. That's when you know you're in menopause. Before that, it's perimenopause. And you don't want to give estradiol because it creates the 4 Bs, one of which is witchiness. So we don't.
4 Bs.
Yes, bloating, whatever. And estradiol can be given orally or vaginally or by a patch, transdermally, or by a cream. What's the difference there? Well, if you give estradiol locally in the vagina, it will treat the vagina, but it won't seep through the vaginal wall so much and get into your bloodstream. So for women who are worried about the generalized effects of hormone therapy, in other words, if they have a family history of clotting, they're worried about thrombosis, that's a legitimate worry. There is a small subset of people who have a congenital clotting abnormality, and maybe they shouldn't be taking oral estradiol. So yeah, they can use vaginal. But also women get something very common in menopause. It's called genitourinary syndrome of menopause. And that means women are going to get atrophy of the vagina. The vagina thins out. It becomes an inhospitable environment for your big bacterial friends, the lactobacillus. The lactobacillus colonize the vagina, to protect women against urine infections. And urine infections come from the bacteria which are living inside of your guts. Those, because the anus and the vagina and the bladder are all close neighbors, they can communicate with one another unwittingly through these bacteria.
Okay.
And the way we keep the bacteria from the anus out of the vagina is from the lactobacillus. Think of them like a little army protecting your vagina. Well, when you go through menopause and things thin out, then the lactobacillus no longer have anything to survive on. They survive on the dead cells from the vagina that are constantly being shed. Think of sheep in a pasture. You've got happy lactobacillus grazing there in the vagina on a nice, healthy, thick vaginal wall. After menopause, they die away, and suddenly those rectal bacteria have free reign and they can move themselves right up to the bladder and start causing UTIs. That's genitourinary syndrome of menopause. It also leads to painful sex. It leads to, dyspareunia. That's painful sex. The scientific name for it. And it leads to things like loss of pelvic floor tone and incontinence and getting up at night and irritability of the bladder, overactive bladder, frequency, urgency, burning, all those things are genitourinary syndrome of menopause. That can be treated with vaginal estrogen, vaginal estradiol, I should say, because we don't want to use any estrogen. We just want to use estradiol.
So this makes me think of my mother, who's 88. Those of us that have advanced age parents and we're dealing with chronic UTI issues in the elderly, this would potentially be a treatment for someone who's at advanced age.
It is a treatment for those exact people. In fact, there are some drug companies manufacturing little suppositories of estradiol that you can put in place to do exactly that. There's also something called an S-string, which is like a little flexible silicone ring that can be inserted in the vagina, and it releases estradiol slowly, but just in that environment. And it's perfectly safe for people who really can't take oral estradiol. Now, why should anybody take oral estradiol? Lots of reasons. Number one is you're going to get the benefits through the bloodstream because all the tissues in your body have receptors for estradiol, for testosterone, and for thyroid, and many, many other hormones. But those are the big ones. So you do want to take oral estradiol if possible, or at least transdermal estradiol. Transdermal estradiol actually has a lower risk of causing clotting. So people who do have that history could take an estradiol patch or cream. But oral estradiol goes through the liver. And when it passes through the liver, it's actually metabolized to give you benefits in terms of lower triglyceride, lower cholesterol, and better protection on your heart.
Interesting. So is it possible to be on an oral and a cream both at the same time?
Absolutely. In fact, that's done. Yeah, because sometimes the oral estradiol isn't going to affect that genitourinary syndrome of menopause. You have to put something in the vagina itself. And it could be a cream or a suppository or a ring. So yes.
Wealth of information, and we all want to keep our army going strong. That's for sure. So professional women, we're dealing with brain fog, poor sleep, irritability. How do you push through? So one of the challenges I had is just finding the right physician. The lack of information about women's health and hormones and I'm not dissing on any doctors, but there's a lot of doctors that just quite honestly don't have the expertise. I had one physician say to me, I'm not well trained in this area, and I recommend so-and-so. And I really appreciated the fact that they just said, I'm not well trained. So tell me, how does that, when doctors go to medical school, is this an area that they have to specialize in, like a gynecologist or a urologist like yourself? Or how does that work in selecting a physician that can really provide you with the right care?
Great question. Unfortunately, our training programs really didn't provide us with this information. Now, you would think that urology and gynecology, which are both heavily involved in the endocrine system, would be thinking about these kinds of things. And to its credit, urology does look at a lot of this, and we are very hormone sensitive in terms of teaching, but not to the extent that women need. It's a little bit more about men, and it's a little bit more about the adrenal gland in urology. Gynecology is being sort of, I would say, led by their professional societies, which have certain standards that have to be agreed upon by a large number of experts, and they were all trained in sort of the traditional fashion. I was lucky enough to find courses taught by Dr. Neil Rouzier at WorldLink Medical. And Dr. Rouzier is a brilliant man who he changed my life literally by showing me in the literature that there is a scientific basis to choose one method of treatment over another, to not be afraid of hormones, and to look at the science behind it to show that bioidentical hormone therapy is something that all doctors should be learning about. And it really led me down that path. And now I'm lucky enough that WorldLink Medical has invited me many times to lecture for them, to help teach other doctors about this. So if people are looking for a doctor who does this thing, they should go to the website of WorldLink Medical and find a WorldLink trained provider who can help them, and they will.
I'm hoping by having you on and talking about this topic that women become less fearful in that, even, because we're in professional settings. We don't want to say, as leaders, as the president and CEO, I don't want to say, hey, I think I have menopause and I can't remember my name some days. I'm going through all these things. We're afraid to have these conversations. But in reality, since I started talking about it, I've learned more. And since I've started to research, I've learned more and more. And I think to myself, why haven't we been having these conversations? And where has the help been? I started researching it before the black box label was removed. But then when that happened, I was super excited about it. But I did hit a lot of dead ends, just like a lot of women do. And you're afraid to talk about it because you don't want to seem like you can't do your job, or you're questioning, yourself and who you are. And the best thing that I did for myself and for women that are listening was get help and go on hormone therapy. And I literally had a moment after I went on hormone therapy. I had a moment, and it was just as fast as the whole issue started with, like, one day, I'm like, I feel just not myself. All of a sudden, it took a little bit being on the therapy before I really felt, and all of a sudden, like the sun was brighter. Like I felt myself again. And it was such a huge relief because I had a father who had dementia. And I was thinking, like, oh my gosh, maybe I have dementia. And you're thinking about all these things going on in the back of your head, and you're trying to do your job and you're trying to maintain. And it's so important that there's doctors like you out there, that people can find help, that really do understand this topic, the hormone topic, and can really help women with that. So do you, moving on, we've covered a lot of your explanations. We've covered a lot of questions. Go ahead. Do you have something?
I was just gonna say, and the sun came out shining, and I've heard this story so many times. It's like somebody just watered me. I was a dying plant. Somebody turned on the switch. I was a light bulb that was off. That something in your physiology, in your brain, in your spirit, all of a sudden reawakened, and it is spring again.
Yes.
And that's the way we should be feeling. We should be feeling optimal. And Dr. Rouzier actually published a book called Normal is Not Optimal. And I think it's worth a read for any of your audience who is interested in this stuff. That is something that everyone can relate to.
For sure. So those of us with our aging parents and aging mothers, that, you're dealing with that chronic UTI. And we see this a lot with our elderly, especially in our dementia or memory care facilities where there are chronic UTI issues. How do we have that conversation with physicians? Or is it we need to find a physician that understands the science behind treating some of these issues, or a urologist like yourself? Where do we begin with our nursing team to get help for those residents that we have?
That's a great question. It is one of the biggest problems, one of the major reasons that people get ill in a nursing home environment. In these institutions, there's a lot of bugs moving around and a lot of very resistant bugs. So how do we prevent infection from happening? A lot of it is, cleanliness and paying attention to continence, but there is a role for those people to ask their doctor about genitourinary syndrome of menopause. Say, this is something I read about, I heard about, I saw it on a podcast. I saw it on Nikki's podcast, on Angie's podcast.
Yes.
and to ask for the estradiol suppository, to ask for a cream that can go down there. It's a simple thing, and it can really help. But there's other things to do. If somebody has urine infections, and the way we look at it, if a woman's sexually active, if she has more than 3 urine infections a year, she needs a workup. If a woman who is not sexually active even has 1 urine infection, she probably needs a workup to make sure she doesn't have a stone or cancer or some congenital abnormality or other issue going on. And the workup is simple. It's just an ultrasound of the kidneys and a quick look inside the bladder with a small flexible telescope. And that can be done in the office. Okay. So there's a very easy solution to that. Rule out the bad stuff and then treat it like it needs to be treated for genitourinary syndrome of menopause. Sometimes that involves taking a prophylactic antibiotic. And that's the bladder has its own natural defenses. Think about the inside of the bladder which is basically a low pressure reservoir, like a balloon. And as it expands, it should be able to store urine without creating a lot of pressure. And the inside of the bladder is very slippery, so bacteria can't stick to it. Bacteria look like little pieces of Velcro. They want to stick to the wall of something. And if a bladder is healthy, they don't, and they're just washed right back out and no urine infections happen. But if the bladder doesn't have its protective coating, which happens after age, chronic urine infections, and menopause, then those little pieces of Velcro on the bacteria are going to stick them there and cause an infection to set up and fester. And that's where an antibiotic on a prophylactic basis can be helpful, just to kill the bacteria before they have that chance.
Is there any going off? It's just coming to mind. If women that are in menopause, perimenopause, is there any advice on nutrition that's beneficial when you're going through these changes? I mean, obviously, maintaining a good nutrition, but is there any particular science or evidence if you're eating more protein or enough protein, or any food advice you can give to us women?
I'm glad you asked that because, yes, to some of the pillars of health are not just hormones. That's maybe one corner of the healthy platform, but you need to have sleep, 8 hours. You need regular exercise. That means strength training 3 times a week and maybe some high intensity interval training once or twice a week as well. And you need a healthy diet. And the healthy diet should include things like healthy fats, monounsaturated fats. Those are almonds and avocado, olive oil, macadamia nuts. Those are those kind of fats. Mm-hmm. They should include low glycemic carbohydrates. You don't want sugar. You don't want refined sugars. You don't want things that are baked or fried or generally unhealthy. Now, I'm not trying to say you can never eat those things, but try to make healthy choices when you're eating these things. I like the paleo diet. Years ago, I was training with a woman who was just in phenomenal shape, And I said, how do you do it? What's your secret here? I just don't get it. And she gave me a book, and it was an introduction to the paleo diet, which was sort of new at the time. And I read this book by Rob Wolf, and then I read um, uh, his mentor's book, and I'm missing his name right now. Lauren is his first name, but he's a PhD who actually hypothesized this paleo diet. Mm-hmm. It's full of great information about what things cause inflammation in your body. And those are the things you should try to stick to. And sorry, now I'm getting my own inflammation here. It's pollen season in New England here.
Yes, it's here too.
I'll take a drink. So if we avoid things that cause inflammation, like grains, like legumes, and certain dairy products, then we probably can lower the inflammatory stimulus in our body that's attacking the immune system, that's keeping us from having healthy cellular function. Because as we age, our mitochondria, the little powerhouses in our cells, start to age. They undergo something called oxidative stress. The oxygen-free radicals start to decrease cellular function. Cellular membranes break down. And we need to pay attention to all these little tiny reactions that are happening, because they're happening everywhere in the body, and it's causing aging. And we can't reverse time, but we can age better. And that's where a healthy diet comes in. So in terms of supplements, we want to build back healthy cell membranes. We can do that by taking omega-3s. Omega-3s are a large component of building healthy cells. Omega-3s are also important in lowering triglycerides. What are triglycerides? Triglycerides are the end product of eating unhealthy carbohydrates. Carbohydrates are stored, sorry about that. Carbohydrates come into the body and they're broken down into glucose. Glucose is quick energy for your body, and it's usually stored in a form that's easily accessible, something called glycogen. Glycogen is in a big reservoir in our body. The reservoir is the liver and the skeletal muscle. So if we eat too much carbohydrate, that turns into too much sugar, and we don't have any place to store the glycogen, then that carbohydrate is now turned into a triglyceride. And a triglyceride is stored as fat, unhealthy fat. That's where fat bellies come from, and fat organs, fat extremities.
It makes so much sense when you talk about the science. There's you can't argue that. Those are the facts.
Yeah. So decrease unhealthy carbohydrates and decrease your triglycerides. Your triglycerides, ideally, if you're measuring them, should be below 100. In really healthy people, they're below 75. Really? And if you take a ratio of your HDL and triglycerides, your triglyceride to HDL ratio should be less than 2.7. If yours is above that, then you have some insulin resistance happening. Insulin resistance is a whole nother issue.
That's a whole nother show.
That's a whole nother show, exactly.
That's a whole nother show. Before we close, there's one other question I have, and I was talking to a friend of mine, and we're around the same age, so we're menopause sisters, as I like to say. But she had quite a bit of weight gain going through menopause, so she's like, "Oh, I'm going to go on some semaglutide." And I said, "Are you crazy? Now you're going to deprive yourself of food, and you already can't think because you have menopause." And I just noticed that it really took a toll on her, because now you've got, all of a sudden, she's not eating, so she's not intaking anything. I mean, she's gaining the weight loss. So my question to you as a physician, are there concerns with this weight loss fad, or I shouldn't call it fad, it's now a everyday practice. People are doing it all the time. They're getting the poke. Is there concerns to be on those weight loss drugs, such as semaglutide or tirzepatide, while you're also going through menopause?
Yes. because all those things, they're tools, and they should be used in the correct form. They shouldn't be used just because people can't stop eating. There are reasons that people can't stop eating. And there are also reasons why people might not even eat and are still gaining weight and can't lose the weight. And those are the things that we've been talking about during this podcast, which are exercise and diet and sleep. Those are the most important things. And once you balance hormones in that setting with exercise, diet, and sleep, if you can balance your estradiol and progesterone and optimize thyroid in some of those people and optimize melatonin and vitamin D, then your body is going to shift into a different gear and you will lose that weight without the addition of tirzepatide or semaglutide. Those are useful things, and they do help people who are otherwise candidates for something like a gastric bypass, which is, really has a pretty high mortality for an operation, especially an elective operation. So yes, those in a severe situation, they may play a role, but for most people, they're not necessary.
So
and they've become a fad.
Talk to your doctor and make sure he's aware of those decisions, because now you can get it anywhere and everywhere. Like I get together with groups of leaders, and they're talking about it's widely used, as I'm sure you're aware as well. And I had wondered, I'm like, how does that work when you already have these other challenges going on? I mean, it was in my head. So thank you for that information. Well, we're going to wrap up our episode today with Dr. Gluck. Thank you for everything you do in spreading the word about menopause. I found you on TikTok talking about it, and I'm one of your followers and one of the ones cheering you on. I've learned so much from you. It's been so interesting, and just hearing more of the science behind it, because there's a lot of information, and you've cleared up many things for me today. So I really appreciate it. We'll have you back sometime to continue our conversation, because I think we have a few other episodes that we've already identified from this episode that we're going to have to keep on talking about. So thank you, Dr. Gluck, for being on the show today. And thank you for everyone who's watching. As always, thanks to our healthcare heroes, and we will see you next time. For more of the Angie Graham Podcast, check out our YouTube channel or our website, theangiegrahampodcast.buzzsprout.com.